We are live. Let's see. Let's see who's joining us. Jerry Overton. Jerry never misses a meeting, man. Paula, Sandra, Eileen. Wow, nice turnout. Liz, good to see you. Mary Hand. Mary, nice to see you. Wow, nice turnout. Some great people on the call. Excellent. Mr. Niskanen, good to see you, sir. Yeah, fabulous. We'll give everyone another minute to kind of make their way from the lobby into the meeting, and we'll get underway. Very excited for today's call. Looks like a nice group. Tom Ray, nice to have you join us, sir. Thank you. All right. Well, let's go ahead and get started. Most of you have been here before on this call. For those of you who haven't, my name is David Hiltz. I am the director for the Citizen CPR Foundation HEARTSafe program. In my other life, I am the director of innovation and customer experience for Code One Training Solutions. I am very, very pleased to have you all join us this afternoon. As you know, each month we look to have, how shall I say, a saw sharpening experience where we get to learn about emerging science and best practices and hear from like-minded people about some of the extraordinary work that they're doing. And I'm going to introduce our guests in just a few moments. But I did want to make a few announcements. Quick reminder to all of you, if you have something that you'd like for us to promote, an event or something that you're doing, please let us know in advance. We'd be happy to let others know about what it is that you're up to and looking to accomplish. I do have some very quick announcements. Shouldn't be a surprise to anyone, but this Friday, Restart a Heart Day, global. There is no shortage of, CPR related activities on Friday for people to learn CPR. So I'm hoping that you're all promoting or doing something actively to promote, Restart a Heart Day, which is October 16th each year. For those of you who do have events planned, I wish you the very best of luck in carrying those out. Also, for those of you who might be like me, that's an occasional memo. There is something happening on October 21st in regards to resuscitation, and that would be in the form of the release of new guidelines by all of the resuscitation councils around the globe. So now we get to kind of the really exciting part of today's webinar, and that's the introduction of our guests. Now, these two young men, before I reveal their stunning photographs, I've had an opportunity to have multiple conversations with them since I stumbled across their recently published research. And I know that you're going to really enjoy the discussion that we're going to have this afternoon regarding okay, we know that AEDs are useful, but should we be thinking a little bit more about where they should be placed rather than, yeah, we place them where people have the means to pay for them. Not to say that that is, a bad idea, but could we be doing something better, or, as we say in Boston, a little more schmott in regards to deploying AEDs? So I'm going to be passing it over. I'm going to be dropping my slides down and handing it over to Chris and Tim that will talk about their recently published study. And I know that you're all going to be thrilled with the information that they share. And I also want to get you ready to capture your questions in the chat function of Zoom. Capture them there, but we're pretty certain we're going to be able to do open microphone at the conclusion of their presentation for what I hope is a really active question and answer period. So Chris, are you ready, buddy? All right, here we go. I'm going to stop the share and you can begin yours.
Can everyone, I guess, can you see the screen okay?
We do, I do.
Perfect. Well, first off, thank you. Yeah, thank you very much for the introduction, Dave. I think both Tim and I are very, very excited to be here and to talk about some of our work and how it fits into kind of our research goals and the resuscitation community in general. So this particular piece was done in international collaboration between Toronto, Canada, and clinician scientists from Copenhagen, Denmark, specifically Dr. Lena Carlson and Dr. Frederick Folk. And then our other Toronto collaborators are Dr. Laurie Morrison and Steve Brooks, Dr. Steve Brooks from Queen's University. Now, before jumping into the actual study itself, we just wanted to highlight that this work is kind of one piece of our general research goal and our message to the kind of the resuscitation community about the importance, or the value rather, of data-driven AED placement approaches. I think between us in Toronto and I'm sure so many other research groups, including those in Copenhagen, we spend a lot of time trying to figure out how we can use data in the form of historical cardiac arrests to kind of guide these placements. And we're primarily focused on two areas: understanding the trends and risk of cardiac arrest descriptively in the past. And we also, on the other hand, have looked at kind of these optimization and mathematical optimization models. So we just wanted to kind of frame this piece in the body of literature and try to get the message across that or hopefully convince the audience that there is value to strategically placing AEDs. So in the study itself, we essentially wanted to compare mathematical placement models to the gold standard of international placement guidelines, because essentially these are really two sides of the same coin. They're both trying to use evidence and strategically place AEDs. Now, the key difference is that these international placement guidelines kind of come to the audience and come to generalizable recommendations that can be applied to different settings. But while on the other hand, these mathematical optimization models can tailor their AED placements using historical cardiac arrest data within the study setting or the setting of interest. Kind of the twist to this is that even though the recommendations that the models develop are site-specific, the method and the model is actually generalizable because it tailors to the kind of historical instance that you see. But of course, we can talk about this later on, but there is kind of the caveat or the cost. There's no free lunch, so to say, of using the optimization models, which is pretty much, you need some historical data and you might need additional technical expertise when thinking about implementation. And also importantly, some sort of centralized decision maker. So what exactly is an optimization model and what does it really do? I think this is a big question on a lot of people's minds. So I figured we could take some time to kind of walk through the inputs and what it requires and kind of the intuition behind the model itself. Starting off with the inputs, like I said, it really relies on data. So historical cardiac arrest data, where have they occurred in the setting, what times of days, things like that. So that is an absolute must. The other thing that it needs is a set of candidate AED locations. So these are locations that you want to, or that you may consider placing an AED at. And then the remaining two is the model also is able to take into account the existing AED placements, because these networks are very large and they can be placed kind of constructively on each other. So in order to avoid kind of over supplying one specific area, we need to be able to look at the existing landscape and optimize moving forward. And finally, the last input is pretty simple. It's just the number of AEDs that you want to optimize. So maybe it's more local, it's more maybe a small number like 10, or maybe it's across the whole city in the range of hundreds. So these are kind of the overview of the data requirements and the user parameters for the model. In terms of the actual intuition behind it and what's the driving force on how to select these AED placements, we refer to the model as kind of mathematical objective function, or some objective of the model. And in our case, we chose to design a model that maximizes a metric called cardiac arrest coverage, which is defined as the number of cardiac arrests that occur within 100 meters from an available AED. Now, there can be different ones, but this is the one that we chose. And kind of the reason why we did this is that there are a lot of factors that come into play when trying to facilitate bystander AED use. So that could be signage, education, things like that. But at the kind of the underlying foundation is that the AED has to be close to your cardiac arrest in order to be able to respond quickly. And that's why most of these optimization models have some sort of distance as their metric, some distance-based metric. And the 100 meters that we actually chose is based on estimates of how fast or how far a bystander can travel in a two-way distance within 3 minutes, which is kind of the recommendation of rapid treatment. So that's what the model tries to optimize when placing these AEDs. And finally, the output is the kind of the optimal AED locations that the model selects. So hopefully that made sense. And moving on to the other side of this study is the guidelines approach. This is the baseline, this is the gold standard, this is what thousands of communities see in terms of guiding AED placement. And for this study, we spent a lot of time trying to design a guidelines-based approach based on the guidelines text itself, so some sort of translation. And we used the 2015, the most recent guidelines out there from the American Heart Association and the European Resuscitation Council. And I put the text here verbatim, and both of them kind of generally state the importance of placing them near witness cardiac arrests. So placements in relatively high likelihood of cardiac arrests, public places with a high density of citizens where the cardiac arrest is often witnessed. So there is kind of a lot of liberty when you think about trying to translate, how to translate that text. And based on our previous research on temporal accessibility and the importance of making sure that AEDs are available, we created two guideline-based approaches. So in the first one, it would be a 24/7 available AED at every unique location of a cardiac arrest, which is pretty straightforward. So if you see a witness cardiac arrest, you place an AED. And the second one is just a spin. It's considering placement or placing AEDs in hotspots of at least 2 witness cardiac arrests. So this is kind of indicating, okay, so maybe one witness is not really a high likelihood. So what if we place it at every 2? And I'll come back to the second approach later. But for now, let's just focus on the first one. So once again, the goal is to compare the guidelines approaches to the optimization model. And when you think about it, the best way, the most robust way to do this would be through a clinical trial. Of course, this is, again, the gold standard of building evidence. And it is possible to do this, but at the same time, it can be really taxing or time consuming to really design and implement and gather enough sample size to really come up with a difference or a measure of impact. So instead, what we did as coming from the engineering side and the computer science side is we designed this in silico trial, which is essentially a replication of a clinical trial, but simulated on a computer, so in silicon. And the way this works is, again, we use retrospective or observational data to assess the impact of these two interventions. And I guess another way that might be more familiar to you is you can think about this as a prospective simulated cohort study. And with this, we can kind of overcome all of the challenges that are associated with the typical clinical trial. And overall, like, we designed this trial the exact same way that you would design a normal trial. We had a trial setting, so Copenhagen, Denmark, and a trial period. And fortunately, with this retrospective design, we can conduct very long clinical trials and with a large sample size to make sure that we get the evidence that we need. We set our control to be the AED placements based on the current placement guidelines. Again, this is placement at every unique witness cardiac arrest. We have our intervention, which is an equal number of optimized AED placements, again with 24/7 availability. And the primary outcome measure that we decided to use was cardiac arrest coverage, using the same definition. And in our paper, we actually took the cardiac arrest coverage and we built a predictive model to kind of estimate what we're actually interested in, the downstream patient outcomes. But I'm not going to focus too much on that, but unless we have time. So the main focus of kind of the upcoming slides are this initial piece. So the in silico trial coming into the primary outcome of cardiac arrest coverage. So we really want to be convincing about the methodology, or rather transparent about the methodology, because the devil with these retrospective studies are really in the details. So to make sure everyone's on the same page and to really understand what we did, here's a visualization of our experiments. And to kind of preface this, we can ask the audience to kind of think of two parallel universes. This might help with this. So in one parallel universe, we have we decide to place AEDs according to a guidelines approach, and then we can evaluate there. And in the second parallel universe, we decide to instead use an optimization model. So let's go to parallel universe number 1. So in our guideline approach, we have the cardiac arrests that are occurring over time in different locations, different times of days, things like that. And from there, we set a trial period or a start of when we wanted to place AEDs. And kind of this start date was not arbitrary in the sense that we chose it because prior to this time in Copenhagen, Denmark, they didn't have the witness status of their cardiac arrest. So even if we wanted to, we wouldn't be able to follow a guidelines-based approach. So from here, we divided the rest of the study period into disjoint time intervals. And for each interval, we placed AEDs in batch. So for an example, in time interval 1, we looked at all of the historical cardiac arrests that occur and looked for the witnessed arrests and placed an equal number accordingly. And then for the second time interval, we did the same thing. We looked at all of the previously occurring cardiac arrest locations and times, identified the witnessed arrests, and placed AEDs accordingly. Now, one of the things that we really want to make sure comes across is that we're not looking forward in time. We're only using the historical data that we see at that time period. So it's not like we're using data or information that we wouldn't have in real life. We're not being clairvoyant or anything like that. So we continue to do this for the remainder of the trial period. And once we have these AED placements, we can calculate the resulting cardiac arrest coverage because we have all the information that we have about distance and placements and so forth. So this was universe 1. In universe 2, essentially the same thing, but instead we use an optimization approach. We have all the same cardiac arrests occurring in the same locations and times of day. We set the same start of the trial. And in time period 1, we look at all of the historical cardiac arrest data, as well as the number of AEDs that were placed in the guidelines approach, because we do want to make it a fair comparison, a one-to-one comparison between these two interventions. And we plug that into our optimization model and optimize, again, an equal number of AED locations or AED placements. So for time period 2, same thing, look at all the historical data, take into account the number of AEDs we want to place, and put it into the optimization model. And the other thing, the other input that we mentioned was that it takes into account the existing placements. So we're building constructively an AED network through this method. So, and then we optimize accordingly. And then we continue to do that throughout the remainder of the study period. And then we can calculate cardiac arrest coverage again. So for the study itself, we use time periods of 30 days. So you can think of this as monthly deployments. Now, one of the assumptions of this retrospective approach is that the AED placements themselves are not going to affect future cardiac arrest incidents. Because right now we're assuming that these cardiac arrests are going to be the same in both universes. So the assumption is that placing an AED in a room isn't going to prevent or cause a cardiac arrest to happen. And hopefully that's believable, but that is kind of the assumption or the crux of this approach. So this is a visualization of the evolution of coverage over time. So again, we have this 9-year study period. And in the blue line here, we have the intervention, the optimized approach, and its resulting coverage. So coverage is on the y-axis here. So the blue line is optimization. The orange line here is the guidelines approach and the resulting cardiac arrest coverage. And what we see is we see a dramatic and significant relative increase between these two approaches. So only placing 300 or roughly 400 AEDs, we cover 15.8% of all cardiac arrests all public cardiac arrests during the study period, compared to a 50% increase of 24% with optimization. So it is pretty dramatic. And to kind of emphasize that fact, we also included the baseline of the actual existing AED placements in Copenhagen in the purple line. So here, the biggest difference is the number of AEDs required to reach this level of coverage, 1,500, compared to maybe a guidelines approach or a optimization approach of only 400 AEDs. And this just speaks to how, again, using data-driven placement strategies can really increase the effectiveness and even the cost effectiveness of AED networks. So kind of building on that idea, one other kind of supplementary analysis was, we thought, okay, so now we see that there is gains, but how many AEDs would actually be needed to reach this 14% coverage when using guidelines or optimization approach? So how many AEDs would we actually need to have a similar performance to the existing AEDs? And what we found here is you really require a fraction. So the y-axis here is the number of AEDs placed after 9 years needed to cover at least 14% of the cardiac arrests in the city. And again, the 1600 AEDs in the actual existing network in Copenhagen compared to kind of this 85, 90% reduction when using a strategic AED approach. Yeah, just letting that sink in a bit. So the kind of the last item to kind of talk about before I summarize some of the results is coming back to the translation of this guidelines text. So like I said, we did spend a lot of time trying to figure out how to interpret this. And in terms of our second solution or second translation of placing AEDs at at hotspots of 2 witness cardiac arrests, we actually found that there were significant differences in the level of performance. So we essentially repeated the analysis of optimization versus the guidelines approach, but this time instead of placing AEDs at every single unique witness cardiac arrest location, we placed an AED where there were at least 2 witnessed cardiac arrest locations. So what this did was it dramatically reduced the number of AEDs placed, because that is actually kind of a rare occurrence to have 2 in the same location. Yeah, so again, the blue line is the optimization approach, which still performs better. And the purple dotted line here is the guidelines approach, our other interpretation of the guidelines approach. And it is really dramatic. So it just goes to show how sensitive placement strategies can be just based on the interpretation of the guidelines text. So to summarize kind of the big picture and the takeaways from the study, we essentially found that optimization could dramatically and significantly improve this metric of cardiac arrest coverage. And in the study, we actually, again, translated this cardiac arrest coverage to primary outcomes of interest, or patient outcomes, namely bystander defibrillation and 30-day survival. And we saw that this 50% increase did translate to significant increases in these outcomes, although at a lower extent, which is expected. But we do see superiority in the optimization approach. And kind of the policy takeaways, or what communities hopefully can think about moving forward, is to promote the use of these data-driven placement decisions. Specifically, we'd love to see optimization because that would hopefully dramatically improve patient outcomes. But if not that, at least some sort of data-driven approach, maybe by locations or by historical incidents. But we can see that this is significantly more helpful compared to kind of the arbitrary or individually driven AED placements that we see now. And kind of paired with this is that we hope to encourage health organizations to act as centralized decision makers. Again, that's one of kind of the caveats of trying to build a robust kind of constructive collaborative AED network, is that you have to be able to kind of know the existing AED locations, gather the resources to strategically place them. And then lastly, just be clear, or at least know the kind of the caution of, or the repercussions of layperson's translations of the placement recommendation, because we do see that depending on how you interpret the guidelines, we can see dramatically different results. So I think, yeah, that pretty much summarizes kind of the chalk and talk slide portion of this seminar, but I'll shift the screen share back to you, Dave.
Okay, thank you, Chris. You know, I think it would be nice. Tim's been very quiet, so not to put him on the spot, but I'd like to hear from Tim, either a comment of reaffirmation or something about what his peers just presented. Tim?
This is kind of putting me on the spot, Dave, even though you say it's not. So for those of you who don't know me, my name is Tim. I'm a professor of engineering at the University of Toronto, and I've worked with Chris for several years on this line of research. And I think I know a few of the people on the webinar. as well. I think Chris presented very well. I think, I mean, the takeaway message here, what we've been building towards over time, was really that, you know, look at the data and have the data help you make decisions about prospective placement. And, you know, sometimes looking backwards in time, looking at historical data is actually okay, because if we don't think the epidemiology and the spatial distribution of cardiac arrest changes that quickly, looking backwards at time at historical cardiac arrests actually give you a pretty good indication of where they're likely to occur in the future. And I don't think what we're doing here is rocket science. It's really just looking at the data the right way, and then making, you know, simulated prospective placements accordingly. And that's what we've tried to illustrate with the research that Chris just presented, and some of the other work that we've done in the past. So maybe that's all I'll say here.
Yeah, nicely done. Well done. Not only the two of you, but your entire team that was involved in your research. You know, I don't want to steal, because I know there's a lot of really talented people on the line. So I want them to have an opportunity to speak. But this is where we kind of come to the point of like, all right, so what does this mean? Can you give it to me straight up? And, you know, there's always been this, particularly around AEDs, like more is better, right? More is better. And more is not necessarily better. Better is better, right? If that makes any sense. So, you know, I really, you know, I'm hearing a couple of pretty interesting things here, like put them where arrests have occurred, you know, proximity parameters, 24/7 availability. You guys didn't talk about ATMs and coffee shops, but that might come up. I'd like to turn it over. Mallory, if you could enable people to, you know, unmute themselves and present questions, that would be awesome. Could you arrange for that?
Absolutely. I am in the works of doing it, but feel free to raise your hand and we will unmute you.
Tom Ray.
Hey, David.
Go ahead, Tom.
Okay, can you hear me?
Yep, go ahead, mate.
Yeah. Well, so first of all, congratulations to Chris and Tim and to their colleagues from Denmark and from Toronto. It's an esteemed group, and once again, they've done some very good work and I think important work. So I have lots of questions, and I will just ask one or two, and then if there's time, maybe at the end, I'll circle back and ask 3 or 4. But so I'm curious, when they talk about sort of geolocating these AEDs in an optimized way, did they require that the AED be located at a sort of a physical location, or did they just sort of plop it down geometrically, you know, in the middle of the road or something to achieve that optimization? And was there a practical consideration when they talk about this optimized location approach?
Mm-hmm. I'll take this one. So in this particular study, we used kind of a more geographic approach to it. So instead of tying it to specific candidate locations, which we have done in the past in other comparisons, in this one, we really wanted to try and design what would really be kind of the optimal guidelines approach. And that's what drove our decision to instead use kind of this geographic and untethered candidate location placements. And this is because when we think about an optimal or the best guidelines approach that we can design, we're thinking about temporal accessibility and spatial accessibility. And specifically, one of the things that hopefully you could do to facilitate that is kind of outdoor placements on these standalone cabinets. So kind of the intention behind this design choice was, okay, we can kind of narrow down a potential location for placement around this neighborhood based on some geographic spread. And then when we select this location as a potential hotspot of cardiac arrest, we can go in and refine and really place an outdoor cabinet and work through those details following that identification. So
yeah, that makes sense, and I appreciate the answer, and I like the solution that does have some practical validity, I think. So my last question would be, you did this exercise where you saw how many AEDs would be potentially saved or not necessary. What about going the other direction, right? So if you have 1,573 AEDs in Copenhagen, how many more arrests could you have covered if you had deployed all 1,573? Did you ever look at that, sort of the other side of that coin, going the other direction?
Yeah, I don't know if Tim has kind of done a study looking at kind of the trade-offs of this problem. I don't know if you want to speak to that.
Sure. Chris, did we look at it for this particular study though?
Not,
we did, right?
Yeah, I don't think we did, not for this one.
Yeah, so that's a great question, Tom. So the short answer is I don't know. I suspect that if I go back, I'm just looking at that slide that Chris showed. I suspect that we would be able to improve even more, right, than what we had shown in the optimization, because the optimization only placed about a quarter, almost exactly a quarter of what is actually out there. At the same time, though, I don't know if we're ever going to get to 100% because there's a pretty fundamental limit of how many AEDs we can put out there. That would be, especially if we're taking the more practical bent, right, attached to buildings or in safe and secure locations. So the short answer is I think we could still improve it a lot, but probably not to 100%.
Yeah, no, that makes great sense. It would be very interesting to look at the shape of that curve. And, I'm sure you have diminishing returns, but exactly. It would be an interesting exercise. Thank you very much. Really interesting.
Bravo. Who's next? Did I see Brandon?
Yes, Brandon. Definitely. Feel free to unmute.
Yep. Come on, Brandon.
Hey, guys. Brandon Odo. I'm a clinician, but I think what you're doing with the data here is so interesting. I have to ask you some sort of philosophical, statistical questions. What I wonder is, the optimized model seems mostly about efficiency. If you iterated this process over a long enough timeline, and I guess if you eliminated redundant kind of overlapping AED placements, do you think you would end up with similar results?
Could you repeat that? I think I might have missed the beginning of it.
Well, so if you continued this process for a long enough time and you kept collecting information using the guideline-based empiric model, and I guess if you eliminated overlapping AEDs that were in the same spots, would you end up in very similar places eventually? Do you think? Meaning, are you predicting kind of what you would end up with eventually?
I can take a stab at this.
Oh, yeah.
I think the short answer is yes, because at some point you'll just have saturated the city, right? There will be an AED on every street corner on either approach, and the performance of the two approaches will be the same. I think the difference will be that optimization will just get you there faster, right? But in the limit, they'll probably perform the same.
Okay. I mean, I guess what that makes me wonder, second, is it seems like using prior arrests to predict your AED placement, what you're actually doing is using that as a surrogate for population density, meaning at particular times, where are human beings? Because that's where they have cardiac arrests. But it's kind of an inefficient way of getting there. If you had that actual raw data, meaning if you could map out where everyone is all the time, and I'm sure we don't have that precisely, but maybe we're getting there with more granularity. If you had that, would it make this whole process easy? Because it seems like even your model is using that same raw data. It's using where people are having arrests as, to help you guide where you're going to place it. But if you just knew where everyone was, could you just get right there, very easily?
For sure. I mean, if you knew where everyone was, you would have a drone hover above them, right? And then just as soon as you see them collapse, you just drop an AED right on their chest or something. But yeah, absolutely. Actually, Dave, can I have permission to share screen really quickly?
Yeah, absolutely. Hold on,
I think
Tim.
this will actually help answer Tom's question. And sorry, I forgot the name of the individual who just asked this question.
It's Brandon.
Brandon.
I'm just going to share two things with you really quickly that I think will give you some insight into what the questions you just asked. So this is a paper that we published previously, and it kind of addresses Tom's question of, so this was based in Toronto, but if you look at 100, let's say look at 100-meter walking distance, 100-meter radius, we were working with in a situation, we had 25,000 candidate locations in Toronto. So these were buildings and public points of interest and so on. And basically we simulated if we had placed an AED in every single one of those locations, and we were focused on a 100-meter radius, let's say, we would have a coverage potential of just under 80% in Toronto. So there'd still be about 1 in 5 cardiac arrests that we couldn't get to, even if we blanketed, at least these 25 buildings with AEDs. So I hope that gets at Tom's question a little bit. And you do see diminishing returns pretty quickly here. And then for Brandon's question, I'm just going to show another picture from another paper. There's a little bit more that needs to be interpreted here, but the question of following, let's say, daytime population, like just trying to understand where people are, that was actually one of the comparisons we did with optimization early on. And what this figure essentially shows, this figure here, is that this is the coverage from optimization minus the coverage of AEDs that were placed according to population. So daytime population density, where the people are. And the takeaway is optimization still beats statistically significant difference. It still beats the performance you would get if you had just tracked daytime population and placed AEDs accordingly.
Interesting. Maybe the missing element here is that people's risk of arrest is not equal throughout their day. Maybe certain activities or certain times a day are higher risk.
Absolutely. Yes, absolutely. Yeah.
Thank you.
Thank you, Brandon. Who else has questions? I'd be surprised if that's it.
Hi, I have a question. It's Paula Lank. And the question is, what are you planning to do next?
That's
If you can, or give any insight.
yeah, I think there's kind of a few directions in terms of this work particularly. Our two main goals are first is trying to pilot this program, because the in silico, the retrospective data is great, and hopefully we can convince a lot of people to follow these data-driven models using it. But I think we'll really be able to convince all of you if we have a successful pilot. So that's kind of one phase. The second idea is looking at this optimization model from a different perspective. So right now, again, we're using some sort of distance metric, cardiac arrest coverage. But what if we could take that up one more level and think about, okay, we know the historical locations and times of day and so forth, but we also know their unseen variables, their characteristics, who was witnessed, who wasn't, things like that, and who had a bystander perform CPR. So taking in all of those characteristics into account, how can we further tailor the optimization models to target those who would benefit the most from an AED? And kind of playing around with that idea of how we can improve optimization models. Of course, that can kind of go down a delicate road of kind of unequally distributing healthcare resources to certain populations, depending on how it's designed. But that's another direction that we were thinking about pursuing.
Great, thank you.
No, thank you, Paula.
I'll just add maybe one to follow up exactly with Chris's point and to Paula's question. We're working on a project right now with Gareth Clegg in Scotland. A pretty interesting project that's looking at looking at access and equity in terms of where the AEDs are distributed. And what we're finding, so there's been research that shows, right, that there's a correlation between cardiac arrest risk and, let's say, lower socioeconomic status. And so you might think that if you were to place AEDs in a certain way, maybe you can cover more cardiac arrest, but maybe it wouldn't be as equitable, or maybe it would be more equitable. It's not so clear. But we're doing some research right now that's actually, we're finding that if we use optimization to recommend placements for AEDs, that you actually make equity better. So you end up placing AEDs in locations that are, we have a score for socioeconomic sort of status of a region. And so basically the regions that are more deprived have a lower score from that perspective. Those are the regions that the optimization tends to put more AEDs in. So not only are you providing more coverage, you're actually improving equity of access. So that's kind of an interesting result that is a bit of a work in progress for us right now.
Yeah, that's great. Thank you very much.
Yeah, thank you, Tim and Paula. Thank you. Other questions?
This is Pam Dodson. I'm just curious as to, you looked at where the cardiac arrests were and placing an AED in that location. How much have you looked at whether or not having an AED in a location means that the AED gets used?
So this was kind of a topic that our collaborators in Copenhagen kind of took a stab at, where they essentially tried to measure the relationship between the distance from an AED to bystander defibrillation. So in their case, their specific definition was that a defibrillator was applied and a shock was delivered. So those steps combined. And they did see, it wasn't 100%, obviously. I think it was below 50% and decreasing as you get farther away. But yeah, that's definitely another piece that's really important to understand, this relationship between distance and cardiac arrest coverage to our final outcomes of interest.
Pam, again, it makes sense that the longer it takes to get back with it, the less likely it is they'll shock. I mean, if the way we understand ventricular rhythms. But I'm also interested in knowing, how did you in these locations let people know that those AEDs were there? Like I know that they don't come off the wall even when they're there and needed all that often. So I'm looking more, have you thought about how do we optimize the actual use of an AED now that we have them optimized in their locations?
Great question, Pam.
Yeah, this is a really good question. And we certainly don't have a silver bullet for this. I think we view the work that we've been doing as really one piece of a much bigger puzzle. And we're never going to be able to use an AED if it's not there to begin with. So our first step is really trying to identify where those good locations are for the limited resources we have to put them out in the field. But certainly it has to be complemented with things that you can imagine, like responder, like smartphone apps, right, to recruit bystanders and lay responders to go grab one and bring it. Other ways to alert maybe people who have an AED in the lobby of their building and ask them, would they be willing to make a one-way trip? There's lots of really great initiatives happening with neighborhood responder programs these days. So I don't think it's a great answer to your question, but I think what we're doing is really only one piece of the overall, trying to solve the overall problem. And I think there's a lot of other work that needs to be done to get there.
Yeah, excellent point. And thank you, Pam. That's part of the HEARTSafe concept, is that, a whole host of things need to be going on in order to really maximize the potential of a favorable outcome. So these have been excellent questions. Did I see Brandon's hand up again, Mallory?
Oh yeah, I just had one more little thought. Just kind of looking at going forward, from like a march of technology perspective. I'm sure that what we'll keep trying to do is improve these odds of coverage by changing your variables there. So I wonder if we could increase that radius of 100 meters to whatever, let's say to 200, 300 meters by, not making people faster, but, maybe making them more mobile, either you mentioned drones, but, we've done things like, you equip first responders with them, or you make, bystanders into first responders, they can go and grab them, things like that. Or if we just had more of them. So if they were cheaper, in other words, then we can put more of them out there. Do those kind of changes affect your model in a underlying way, you think, or it's just a linear effect? If we double their radius, do you get twice the coverage? If you have twice the number of AEDs, you get twice the coverage, or does it change the whole model itself?
That's a really, really good question. I'm just going to go back and show you another picture, if I can if I have Dave's permission to screen share. I would just say very quickly, I think doubling the number of AEDs is not going to get you double the performance, because like we saw that diminishing returns before, but doubling the radius for a fixed number of AEDs, I think potentially it gives you more than double. So this is another picture from one of the papers I showed earlier. And the idea is that this is a trade-off between number of AEDs you're putting on the y-axis and the range on the x-axis. So, and the idea is that each one of these curves is an ISO coverage curve. So that means, at an effective radius of 80 meters and I had 120 AEDs, that would be the same as if I had 80 AEDs and let's say 130 meters range and so on. So basically what you see is if I double my radius from, I don't know, 100 meters here, I pick one here, 100 meters to 200 meters. Let me pick a more easy one. So let's say, sorry, it's not really easy to tell, but if I kept, about 130 AEDs and I went from a radius of 100 to 200, I'd be moving my coverage from, I don't know, 30% to, I guess maybe not double, so to 40 something percent. So you do get, I guess it's diminishing returns in both directions, but you can tell what type of improvement you can get by either increasing AEDs or increasing the range, or potentially doing both.
Yeah, it's interesting. It seems like the most sensitive variable is, that radius. So if you could find a way to kind of give your AEDs legs, that would probably give you more bang for your buck than just putting them out there.
Yeah, exactly.
Bicycle.
One of the things that I think a lot of communities are working towards, like you mentioned, is the bystander AED apps. And I think that that's a really interesting way to try and extend this radius, like you were saying, because the 100 meters, again, is based on a two-way distance. We're assuming you're at the victim, someone else is there, so you're able to go and grab an AED and come back. But if we had kind of these live bystander responders, we could potentially double that radius, because we can activate someone who's kind of close to an AED to bring it straight to the cardiac arrest victim. So that's one potential way to try and extend that radius.
I think, this is Pam again, we did use HEARTS AED Link in Contra Costa when I was there, and it does really make a difference if you're only going one direction. If you can alert the person who has the AED and they already know where it is and how to use it, it takes a lot less time to get them there than if you have to go get into the door, find it, do the whole thing, ask to use it or whatever, and then go. So it does make a difference if it's one direction.
That's really interesting. Yeah.
Excellent. Great discussion. I think, did Bob have his hand up, Mallory?
Yeah, so Bob has submitted a question. Bob, do you want to unmute and
Yeah,
ask?
please.
If not, I can just ask it on his behalf. He says, it is good to see engineers active in this area. Are you collaborating with folks in Singapore, Copenhagen, Stockholm, Amsterdam, and Paris? They are actively using smartphone apps too.
I guess I can respond. Maybe Chris can respond separately if he's starting collaborations as well. But we have been talking with, we've obviously been collaborating with folks in Copenhagen. With Singapore, we have visited Marcus a year or two ago now, and we were trying to carve out some projects, but we haven't formalized any concrete projects yet. And for the others, we just haven't yet unfortunately, there's only so much time that we have, but certainly I think your suggestions about working together, especially on the smartphone apps, would be a really great collaboration.
So it's Bob here. It could be a great virtual meeting if you added leaders from all those cities. They're doing tremendous work, and it's really good to see what you guys are doing up there in Toronto land.
Thanks, Bob.
Yeah, thank you. I was really impressed from the get-go, and I've been, more impressed the more I've had an opportunity to converse with these two young fellows. We're coming up on the hour.
So Dave, one more comment there, Dave. Why don't you and I and Paula and Pam and a few others strategize for a virtual meeting associated with Citizen CPR Foundation on this very topic and bring all the players together from these 4 or 5, 6 key cities?
Yeah, without a doubt, that's an excellent suggestion, Bob. And just so you know, I've already had a couple of discussions with both Chris and Tim about, we'll be seeing you in San Diego, right?
Very good.
And at least one of them is looking to become a member of the 40 Under 40 Club. So in any event, Chris and Tim, you've been fabulous. Our guests have been equally fabulous and presenting some great questions. I'm still like, geez, what do I do with this? Like really good lever, right? And so I think we need to kind of digest this a little bit further and see how we can best utilize the excellent research that you've done. But before you all go your merry way this afternoon, I'm going to ask, and we're going to do it open mic. You can also use the chat function, but how are these champion webinars going for you all? Many of you have been to, a handful of them now. Is this useful information? Are you finding these beneficial? Do you have new subjects that you'd like to share? Has this been just a horrible waste of time and time that I'll never get back? Your feedback is extremely important to us. Please let us know. I see a couple of chats coming in, but if you want to unmute your phone, your mic, and let us know, that would be great too.
This is Mary Hand. This was my first championship webinar, and I thought it was excellent. Just a great use of my time, and I really very impressed with the presenters, and thank them for their time, and just I can't encourage them enough. And I second the comment about the importance of the engineering expertise in helping us solve this huge problem of out-of-hospital cardiac arrest. So thank you.
Mary, thank you. Coming from you, that's an excellent compliment. Appreciate it. I think I saw Liz raise her hand. Could we unmute her, have her speak?
Yeah, this is Liz Lazar. Since there's no in-person conferences these days, no ECCU or Parent Heart Watch, this is really the best way for us all to get information about the new things that are going on in our field. So I've attended a couple of these now, and I find them really informative, and I hope you keep them up.
Excellent, and we will. Any other comments before we move on? Brandon says something positive. Excellent. So, everyone, thank you as always. I know that you're all very busy doing your role, critical roles, and helping people live longer, healthier lives. On behalf of the Citizen CPR Foundation, their board of directors, and the HEARTSafe Program Advisory Committee, I'd like to thank you for all that you do and hope that you have a fantastic remainder of your day. And we look forward to seeing you next month. Until then, take care and be well. Ciao.